So thank you very much, Professor Chen. Thank you for the invitation. Let me also please congratulate you and the colleagues from Taiwan and all the other international participants who have kept this very, very important international meeting going for so many years. It's really, I think, such an important achievement. I'm very grateful to have the opportunity to join my friend Linda Rabenak in a joint keynotes to launch this meeting, and let's get going. So we all have seen these pictures. They exist in every single country in the world of exhausted healthcare workers, the very, very busy ICUs. When the pandemic arose and it was dedicated as a pandemic, we clearly, there was a sense of urgency to basically devote all healthcare resources to dealing with the pandemic. And that meant that what was thought of as all non-urgent care, non-essential care was suspended. It's understandable. It turned out to have been a mistake. You can look at these numbers and you can see the degree to which the burden of disease of COVID-19 has not been evenly distributed around the world, but we're up to over 250 million cases and over 5 million deaths. Some countries have been particularly hit hard and not managed the pandemic well. My country in particular stands out, whereas Taiwan really is a global model of how to have reacted promptly and quickly and minimize the adverse effects of the pandemic. So congratulations to the Taiwanese colleagues. When we look at the potential mechanisms, though, of the impact of the shutdown of healthcare on cancer, we're particularly focused on the disruptions in the screening programs, which literally stopped. But there were also delays in the presentation of symptomatic disease and even response to symptomatic disease, and very little guidance in the process, which must have been particularly bewildering to people who were very worried about their symptoms. There are other effects on cancer in terms of survival of people who had the disease, people with weakened immune system. Everyone essentially was very close to being orphaned in this process. And there have been a number of surveys that have attempted to measure this. The International Cancer Screening Network sent out a survey that got pretty good response. The goal was to gather information about the mechanisms that led to the shutdown of services and any attempt to reopen them. And you can see the countries that were represented all over the world, so we think it's actually quite useful in this respect. What you see is that most settings suspended their services in March. Most of the suspensions of service were guided by countrywide government decisions and advice. And very few settings reported that anything in their contingency plans for healthcare disruptions, which are typically for disasters of one kind or of another, had any guidance for what to do in the presence of a pandemic and how long you might actually even take those steps. The WHO sent out a survey to 155 countries and found that screening programs in the majority of them for non-communicable diseases, so this would be even more than cancer, were disrupted, and 55% reported disruptions in cancer diagnoses and treatment. In England, just recently in October, Crawford and Edwards and Zoltowski published a short letter called England's Stalled Cancer Progress. And I think that's a particularly worrisome conclusion to draw at this point, that we not only had a hiatus in services, but we have enduring reductions in progress. We have experienced a setback that we have not entirely recovered from. And what they noticed here is that although the requests for radiographic services from primary care plummeted in 2020 compared to 2019, at this point later in the year, in 2021, they still have not recovered. They are still experiencing 20 to 30% fewer requests from primary care for radiography services than they had in 2019. And so we have to ask ourselves, what lessons have been learned? Let's see if I can get this out of the way. What lessons have been learned? In most national and local health systems, few have comprehensive plans in place for healthcare disruptions. And by comprehensive, I mean the maintaining the delivery of services that are investments in the future, such as detecting occult cancers that otherwise would be able to progress to advanced cancers. The reaction of the pandemic was the first priority. We can understand why that was abrupt, but there was not a plan to guide it. And it quickly became apparent that much of the suspended care was neither elective nor non-essential. And the costs of this reactive policy, the costs of the failure to recover from the backlog of unmet care, the disruptions in the patterns of care, and the continued medical distancing have revealed that this pandemic will be associated with not only a global increase in deaths from COVID-19, but a global increase in advanced stage cancer diagnoses and premature cancer deaths that could have been prevented. In a very nice editorial that was recently published in the International Journal of Cancer, it was stressed that the global burden of cancer is growing. It's a very significant disease. It's a very significant cause of morbidity and mortality. And it has roughly in a given year over twice as million deaths as we experienced from COVID-19. And it's projected to rise. And we have many of the tools in place to reduce that increase if we can only apply that knowledge. And we can see now that our response to an acute onset pandemic resulted in increasing the disease burden and the costs of a prevalent, less acute onset pandemic, which would be the cancer pandemic. And we ought to be thinking of cancer as a pandemic. And for reasons that have long historical underpinnings, and it really does help us understand the reaction, is that cancer is judged as less urgent, even though there are poor outcomes from failing to interrupt the natural history of the disease through early detection or delaying diagnosis and treatment. Why is cancer control fundamental during a pandemic? It's clear that if we do not maintain cancer control in place, screening, diagnosis, and treatment, we bear the costs later on. We can't just stop them. They don't wait for us to resolve the infectious disease challenges. The International Cancer Control Partnership is working around the world to help countries develop comprehensive cancer control plans. These are going to be integrated into the non-communicable disease efforts to achieve the United Nations Sustainable Development Goal of 30% reduction in premature mortality from non-communicable diseases by 2030. It is clear now that these plans must address contingency planning to guide the continuation of cancer care during infectious disease pandemics or other health disruptions. The Asian Cancer Centers Alliance came up with 9 Ps in preparing for the next pandemic. This is visionary and it ought to be taken seriously by everybody. The main priority, the rest are operational, but the main priority is to understand we must maintain cancer care as a key priority in a healthcare system response, even during a global infectious disease pandemic. I want to show you these slides, which also lead me to conclude that we have our work cut out for us. We compared breast cancer, colorectal cancer, and cervical cancer screening in England and in the United States. One country has an organized screening program, the other, United States, is opportunistic. And we asked the question, what percentage of the population is adherent with all the recommended cancer screening tests? And as you can see in this slide, it differs considerably from the uptake of any individual test. So in the UK, only 35% of the population is adherent with all the recommended cancer screening, and in the US, only 44%. And that tells us that we're not clearly communicating with the population about the importance of routine and regular early cancer screening tests. We need new enhanced communication with the public about cancer screening, not only outside of pandemics, but during pandemics as well. We need to stress the importance of regular adherence to all recommended cancer screening tests. We need to stress the importance of understanding that cancer screening is not a non-essential service. It's not something that can be put off. Continuing cancer screening, diagnosis, and treatment during a health disruption is part and must be part of a comprehensive response plan. And we also need to ensure that the public can be reassured that the safety of screening of health services when personal protection is still required. So in final thoughts, we can be forgiving that we were not prepared to respond swiftly and decisively to COVID-19. Some nations were prepared, some were not. And there were well-intentioned decisions made to prioritize health services to combat the virus with little appreciation of the potential long-term costs. We have learned this lesson, and now is the time to develop more comprehensive disaster and pandemic response plans that not only focus on affected individuals, but maintain important health services that also are important to avoid premature deaths from cancer and other chronic diseases. It's important to prepare the public for these in advance, and it's important that they understand that this needs to be routine preventive health behavior going forward. And I thank you very much again for the invitation to be here with you today.